So good afternoon, everyone. We are going to start with a session on pregnancy and skin disease. We have 4 excellent talks today. So I think we are probably ready to get started with our first speaker, who is Professor Robert Mullegar. He's a director of the Department of Dermatology of the University Clinic in Vienna, Neustadt. And he's going to talk about polymorphic eruption of pregnancy. So, Robert, the floor is yours.
Thank you, Sarah. Good afternoon, ladies and gentlemen. I'm delighted to open this session on pregnancy and skin diseases with the topic of polymorphic eruption of pregnancy. Polymorphic eruption of pregnancy, which I call with the abbreviation of PEP from now on, is a specific dermatosis of pregnancy, and specific dermatosis of pregnancies are defined as a heterogeneous group of pruritic inflammatory dermatoses which exclusively are associated with the time of pregnancy and or the postpartum period. They make up about 50% of all skin problems during pregnancy. And aside from PEP, they include atopic eruption of pregnancy, pemphigoid gestationis, and intrahepatic cholestasis of pregnancy. The most common one is atopic eruption of pregnancy that accounts for half of all those specific pregnancy dermatoses, followed by PEP that accounts for a quarter of those problems. So polymorphic eruption of pregnancy is a benign, self-limiting inflammatory skin disease that is limited to the skin, goes not along with extracutaneous signs and symptoms, and affects about 1 in 200 pregnancies. Although there are no extracutaneous symptoms, there is severe pruritus in all patients, which causes a massive maternal discomfort, including sleep disturbances and great emotional distress. It's not always straightforward to discern those 4 specific dermatoses of pregnancy because all of those go along with massive pruritus, and they also assume at time several morphological features that are overlapping. However, it's very important to discriminate those 4 specific dermatoses of pregnancy because some may be associated with adverse fetal outcomes, including preterm birth, fetal growth restriction, low birth weight, fetal distress, and in some cases even stillbirth. The specific dermatoses of pregnancy that are associated with adverse fetal outcomes are intrahepatic cholestasis of pregnancy and pemphigoid gestationis, and there is a 5th one that Sarah will talk about that later, or actually Bridget, I'm sorry. It's pustular psoriasis of pregnancy. One clue to discriminate the 4 specific dermatoses of pregnancy is the time of onset. And please note that atopic eruption of pregnancy is the one that occurs the earliest. It's within the first trimester or the early 2nd trimester, whereas intrahepatic cholestasis and pemphigoid occur during the late 2nd trimester and the 3rd trimester. Most important when talking about PEP, this is the one that occurs the latest in pregnancy, most typically within the last month of pregnancy, but at least 80% or more of pregnant patients who develop PEP do that within the late pregnancy, 3rd trimester, and about 15% may even occur postpartum. As the main differentiation has to be made between pemphigoid and PEP, please note that polymorphic eruption of pregnancy occurs even later than pemphigoid. Also, there are some predisposing factors in PEP that may help to support its diagnosis. First of all, it's important that PEP occurs usually in first-time mothers, in more than 2/3, sometimes with a high body mass index. And another very striking feature is that it is associated with an excessive maternal weight gain and or high fetal birth weight in almost 80% of patients. And this also goes along with the fact that PEP is more commonly seen in multiple versus singleton pregnancies. The ratio here is 16 versus 0.5%. Also, there is a fetus gender ratio of 2:1 in favor of male fetuses, and PEP occurs significantly more often, 4 to 8 times more often, in cases of in vitro fertilization versus normal pregnancies. Whereas there is no known genetic link to PEP and no association to any autoimmune disposition, specific HLA type, or pre-existing skin condition, and the family history is also usually negative. Regarding the clinical presentation of PEP, there is a previous, actually obsolete, but sometimes still synonymously used term for PEP. It's called pruritic urticarial papules and plaques of pregnancy, and this old term actually perfectly describes the initial stage or the skin lesions of the initial stage of PEP, namely small urticarial papules and plaques, often with a pale halo, which start on the abdomen. The abdomen is always involved, or in nearly all cases involved, in PEP and or the proximal thighs. And the yellow underlined features here are very, very important for PEP. They are most characteristic for the clinical appearance, namely, first, PEP in the majority of patients starts within striae distensae, and there is another important feature: the periumbilical region is characteristically spared, and this is in sharp contrast to pemphigoid, where the navel is usually involved. Pruritus in PEP starts simultaneously with the skin changes. Later on, over days, the papules coalesce into larger plaques and spread to the buttocks, the thighs, and the rest of the trunk in most patients. Generalization is seen in rare severe cases, and also involvement of the distal extremities is very rare. The face, palms, soles, and mucosae are spared in PEP. Not only that PEP lesions spread over time, do they also assume a polymorphic appearance over the time of several days, with eczematous changes more often seen than vesicles and dargetoid lesions, as well as widespread erythema. But polymorphic appearance occurs in at least half of patients with PEP. However, bullae are almost never seen. There are only 2 descriptions in the literature about bullae, and this is again a very important feature to discriminate PEP from PG, because PG usually, of course, goes along with bullae. So, after having described all those features, it's becoming clear that polymorphic eruption of pregnancy is the preferred term for this condition over pruritic urticarial papules and plaques of pregnancy. There are usually no excoriations and no post-inflammatory hyperpigmentation with PEP. The pathophysiology of PEP is still unknown. There are only theories, with one leading hypothesis that sets forth that the excessive maternal weight gain that is typical for PEP leads to a rapid distension of the abdominal skin, and in turn leads to a connective tissue damage within the striae and therefore to an exposure of antigens within collagen. And finally, an allergic reaction is sparked to those antigens. And the so-called fetal microchimerism hypothesis relates to the increased rate of male infants in PEP and sets forth that there is a deposition of fetal male DNA in maternal skin, which again leads to an immune reaction. People also say in the literature that this reaction favors skin with increased vascularity and damaged collagen, as in the abdomen of PEP women. The differential diagnosis of PEP include first coincident pruritic dermatosis like urticaria, viral exanthema, or drug eruption, and more important, even more important, are the specific dermatosis of pregnancy, which may go along, as I said, with increased fetal morbidity. The main differential diagnosis in considering PEP is pemphigoid gestationis, in particular during the pre-bullous stage, as PG and PEP present actually with the same or at least similar clinical features, namely urticated papules and plaques on the abdomen and limbs, and both go along with really intense pruritus. But PEP does not go along with pregnancy complications, whereas PG confers maternal as well as due to placental insufficiency fetal risks, which include prematurity, small for gestational age babies, sometimes stillbirth, as I said, and about 10% of the babies develop a transient neonatal rash. In mothers, a problem is the trend for recurrence of PG in subsequent pregnancies. And this, of course, entails a different management of pregnant women with either PG or PEP, including systemic medications and monitoring of the pregnancy. The diagnosis of PEP is based primarily on clinical presentation and is essentially a diagnosis of exclusion because routine lab examinations are normal, which helps to exclude intrahepatic cholestasis of pregnancy. Furthermore, there are no characteristic histological findings, and direct immunofluorescence is consistently negative, which is a very important feature to differentiate versus pemphigoid, because here the direct immunofluorescence is positive. So in typical cases, a biopsy of the skin is not necessary in PEP patients. Also, indirect immunofluorescence is negative. It does not show circulating IgG antibodies to PP180 as in pemphigoid gestationis. If you do a biopsy of lesional skin in PEP, you will encounter the following characteristics. First, you see a superficial and sometimes deeper, primarily lymphohistiocytic, perovascular, and occasionally interstitial infiltrate that more or less resembles an arthropod reaction. And in 1/3 to about half of patients, there is a variable admixture of eosinophils and some neutrophils. Also, there is an upper edema, an upper dermal edema, and some epidermal changes like spongiosis, mild focal spongiosis, and parakeratosis. And later, the epidermal changes are, of course, more commonly seen and more prominent in advanced lesions when polymorphic appearance is clinically present. So a group from the Mayo Clinic investigated differences between histopathology of pemphigoid gestationis and PEP, and they found several characteristics, in particular related to eosinophils, which are different from PEP, namely eosinophilic spongiosis and epitheliotropism in pemphigoid, a significantly denser dermal eosinophilic infiltrate, and even interstitial spread of eosinophils. However, blister formation, subepidermal blister formation is still the most characteristic and important feature of pemphigoid gestationis, whereas subepithelial separation is absent in PEP. However, as there are histopathologic as well as clinical overlapping features in PEP and PG, direct immunofluorescence is still the golden standard for diagnosing PG, where a linear deposition of C3 is usually found along the basement membrane zone, sometimes also IgG. Fang Shi and her colleagues, it's the same group who did the histopathology work at Mayo, further elaborated on an older score to differentiate between PG and PEP solely on clinical history and examination findings. So if if histopathology is delayed or not available, and they ascribed -2 to +2 points to features which are very typical or typical for pemphigoid gestationis or are absent in this disorder. And they were able, with a very high specificity and high sensitivity, to discriminate the two diagnoses by these features, and the most important ones clinically are umbilical involvement in PG as well as blistering, and a history of previous pemphigoid in previous pregnancies, as well as an onset before polymorphic eruption. How about course and fetal risk of the disease? So there is no risk from the disease to the mother. The rash is generally short-lived, severe for probably about a week, and resolves spontaneously over 4 to 6 weeks independently of delivery. So as a rule, there is no indication for early delivery for relief of pruritus. Recurrences, as seen in other pregnancy-specific dermatoses, are very rare in subsequent pregnancies in PEP and occur usually only if there is a multiple pregnancy later on, and those episodes are usually milder than the first one. Also, PEP is not triggered by the intake of oral contraceptives later on, and there are also, which is very important, no adverse fetal outcomes, and there is no cutaneous involvement of the newborn. How about treatment of PEP? This is symptomatic, meaning it is aimed at relieving pruritus, and first-line treatment, including topical glucocorticosteroids and oral antihistamines, are satisfactory to control symptoms in most patients. Emollients render additional symptomatic relief, and they may also be admixed with antipruritic additives like urea, menthol, and polytocanol, which are, by the way, safe in pregnancy. Second-line treatment includes narrowband UVB treatment, which is, however, rarely needed because the disease is usually short, and oral corticosteroids are to be considered only in severe cases of recalcitrant pruritus. If you are using topical corticosteroids, please go for low to moderate potent agents like methylprednisolone or mometasone, because they are effective and there is no causal association between maternal exposure and adverse pregnancy outcomes. In the cases where potent agents are needed, A total dosage limited to below 300 gram during the entire pregnancy has to be taken because there is a possible association between an extensive use of high-potency agents and low birth weight. However, there is no increased risk of teratogenicity or malformations from topical corticosteroids. Regarding antihistamines, you should use second-generation antihistamines instead of first-generation ones because they are more selective and less sedating. The antihistamines of choice are loratadine and cetirizine in a daily doses of 10 milligram. They are among the most studied drugs in pregnancy and have been shown to be non-teratogenic, thus being considered as the safest antihistamines and treatment of choice in pregnancy. Regarding first-generation and sedative antihistamines, these are the antihistamines of choice in early pregnancy, but caution is advised during the last month of pregnancy when PEP occurs, the time when PEP occurs, because they may sometimes cause uterine contractions, neonatal sedation, and respiratory depression. Finally, a word on systemic glucocorticosteroids, which are only to be considered in severe cases, and the short course usually leads to a quick relief of symptoms. Typically, you would use prednisolone because that is largely inactivated in the placenta. You start with a dose of 0.5 to 1 mg per kg per day for a few days and taper it off quickly within 1 to 2 weeks. This procedure is not associated with fetal or neonatal adverse outcomes and rarely produces mild and transient maternal side effects like hyperglycemia or fluid retention. So I would like to wrap up now with my take-home message. Polymorphic eruption of pregnancy is an intensely itchy rash consisting of urticarial papules and plaques that occur at the end of pregnancy or postpartum, usually beginning in the striae and typically sparing the region around the navel. And it is not associated with adverse fetal outcomes. Thank you for your attention.
Thank you, Robert. That was a brilliant presentation and really comprehensive. Should we go ahead with the presentations and do questions at the end?
I guess that's a good idea.
Yeah?
Well.
Okay. So I'm now pleased to introduce Brigitte